Okay, welcome to the top ASaP webinar on the IHI model for improvement. My name is Nolan Schaff, and I'm an improvement facilitator with the Chinook Primary Care Network. This presentation today is on the IHI model for improvement using an example from the Chinook Primary Care Network on cervical cancer screening process development. So a little background on the scenario today. The newbie clinic is the example that we'll be using today. Of course, this is a fictitious clinic. The newbie clinic joined the Chinook Primary Care Network in 2011. And so it joined the CPCN and decided that it wanted to create an improvement team to support practice improvement on the clinic for the clinic, focused on three main areas: access, efficiency, and clinical care. And this is something that the Chinook Primary Care Network had a lot of experience doing. And so they created their improvement team, and they had a number of representatives from different functional areas in the clinic, including physicians, administrative staff, and clinical staff. Initially, the team focused on team development, including incorporating and hiring new clinical staff, including RNs and LPNs, and they worked to develop a pod structure. In 2012, they went through an EMR migration to one of the three main VQer vendors, and now they're looking at really developing comprehensive clinical screening processes. And so they chose cervical cancer screening as one of the areas to start. So looking at it through the model for improvement, the first question they asked was what are they trying to accomplish? As part of the goal to create a comprehensive clinical screening program, the team decided that they were going to create a process to manage all of their cervical screening for all eligible women. They wanted to capture a number of comprehensive things, including all levels of risks, so not just low risk. They wanted to reflect the current clinical practice guidelines. And they wanted to provide opportunities for clinical decision making, so they wanted to provide supports through the EMR. The next question in the model for improvement is, how will they know that the change they've made is an improvement? They decided that in order to know that they were going to make an improvement, they would have to develop an understanding of the current system. And they recognized quite quickly that there was no current process that formally existed. There were a number of physician-specific practices, and many of them working well, but they had no formal process. Many of the processes were managed by experience and memory, or by patient request. There was no formal role for the team, and especially for the RNs and LPNs who were newly hired. And there were no concrete processes, standards, or guidelines that were being followed at a clinic-wide level. So in order to know that they were going to make an improvement, then they had to develop a future state process, and by doing that, then they could figure out what they needed to test and try to make that improvement. And so they wanted to develop and trial a PDSA to test the process. So the third question are, what changes could they make that would result in an improvement? And so they had to assess the current knowledge and tools so that they would be able to utilize both the knowledge and skills within the team, as well as to figure out any gaps in the process and in the knowledge and skills of the team. So they did an assessment of the physician knowledge and experience. They did an assessment of the current clinical practice guidelines supporting cervical screening. They did an assessment of the tools available through their current EMR, and they had gone to a new vendor who had quite a number of tools to support this. And they also worked to assess the skills of the team. So they had MOAs, LPNs, and RNs, all of which who had they had capabilities of helping in this process. Given that assessment, they were then able to develop a proposed process map so that they had an understanding of how they could integrate all of these different things into a new, improved process for cervical cancer screening. From there, they wanted to develop a PDSA to test out, and then once they had confirmation that this was actually going to work, they would work on a spread plan so that they could spread this to the entire clinic operation. And so, given all that information, they did develop a new process map, and this here is an example of the future state process map that they wish to try. So, without going into too much detail, they essentially would identify the process for identifying patients who may be due for cervical cancer screening, and as the information was limited in their EMR, they had to set a fairly broad screen so that they could assess patients for the specific level of screening which they required. At which point they would determine whether a patient was due for the PAP or not. If they were due for a PAP, then they would go on to offer that intervention. If they weren't, they would offer an exclusion, so they would be reviewed through the EMR at an appropriate time. Once the PAP was completed, the office would receive a result, and the physician would review that. However, they also recognized that they wanted to put in some automated processes around their EMR, and so they set up a process where the clinical team would actually receive those results as well. And then they would apply protocol-based decision-making to those PAP results to determine when they were next due for a PAP, whether it would be an abnormal result with a short-term follow-up, whether it was an adequate specimen, or whether that patient would then be eligible for the routine 3-year screening. Once those things were completed, the process would be complete until the patient would book a next appointment. It's important to note at this time that they did not believe they had the capacity for outreach, and so they stuck directly with opportunistic screening at this time. And so after the completion of the map, they worked to develop a PDSA. And so they really wanted to, they had a clear aim to understand what they were trying to achieve was to improve the tracking and follow-up for PAPs at the clinic. And they determined that using the preventative care function in Wolf, which was their EMR, they were going to develop a new trigger and then use the preventative care field to track those interventions over time. They did have concrete measures in place where they would measure how many patients per week were PAPs being performed and how many results were being received. They wanted to make sure that every result that they received actually matched up with a patient who had had a PAP and that none were missed. They also wanted to put in some tracking around the volume and workload of this because this was a new process. And so they set up a measurement system around that. And they also did a prediction to see what they thought would happen. And they did predict that PAP reminders would be more efficient because they wouldn't have to spend all their time reviewing scanned documentation. They believe in the long term that they wouldn't have to search charts because all their documentation would be more organized. And they also anticipated that extra data will have to be entered into the preventive care field in this first round. And they anticipated that this workload would be manageable, but they wanted to verify that. And so they endeavored, because the scale of this test was a little bit broader, they did want to test this for 4 weeks, and they endeavored to actually do account of the workload and the amount of time this would take, as well as the opportunity to write observations and notes because this was a new sort of process improvement. And so what we have here then is they went into the process, and this is where process improvement reality meets the the perfection that we would like it to be. We had our team meetings and we reviewed how the process improvement was going. They did implement the PDSA partially, but they didn't collect their measures as defined. And so we just discussed that and determined that we would implement the measurement plan and we would review that with the team. We also recognized that sometimes entering data took longer than anticipated and there was more data to enter. And so they also found that they needed some resources for decision support. So at the next steps, they decided they were going to actually do their measurement and provide some step training to other staff. A few weeks later, we came back to their next improvement meeting, and we got a report back from the individual physicians, and we found that the volume of work was manageable. There were a few issues that they wanted to work out technically through the EMR, but everything seemed to be working well, and it wasn't taking too much time. They also found that the physician had a role in communicating with the patients what this new screening was about and when they would be due for repeats, and that seemed to be working well as well. And so last we decided that we were going to review the process and make sure that we were actually sticking back to that process map. And then we discussed spread and had a second MOA start to do the same process. The clinical care coordinator was then going to get a copy of some of the technical requirements for the EMR and do the training for that individual as well. And so through this process, we determined the process was working and that we would spread it to other physicians and try it out. So in summary, using the IHI model, we were able to create a common understanding of the goal and get the large team on board with that. We identified that there were changes that could be made given the current resources and abilities of the team, and we figured out what those changes were. We identified that a plan could be or should be developed in order to understand if those changes actually created the outcomes that we desired. And the cool thing about doing this all as well was that as we went through this process, the team was building capacity beyond this individual project. They were understanding how do you set goals. They were understanding how do you explore opportunities and how do you actually increase the scope of different clinical staff. And so we really worked also to discover how process improvement works in reality. When they didn't do the measurement system, we didn't sacrifice all the learning that had happened during that time. We continued to move forward and figure out a better way to collect information in a timely and simple fashion so that the team could do their work while also understanding their work. And lastly, we provided the team with the opportunity to build